Was some very minimal reimbursement related to interpreter services. The discussion I had around that space when I left was actually the fact, there was some back and forth about how there had been an incremental cost added in mass health reimbursement with something like 1 cent per dollar. And it was all hypothetical about how can you prove it's there versus not being there. I can say that I'm aware of some programs like the Medicaid program in New York that are beginning to offer that type of reimbursement in 15-minute increments. So that is changing the discussion in other states in terms of how they want to engage and involve the payers in the process. One of the other questions I've been asked at the break actually was about the brief intervention piece, whether that might become reimbursed. You know, one of the questions that needs to be answered yet is what exactly people want from that payer side of the experience, right, and what the payers want from that side. You know, if there's clearly a service they believe is valuable to their insurer, their insured patient base, then the question becomes, what are they prepared to do to engage with providers in the space to ensure that's facilitated. I think historically they've been looking at it from a mandate perspective in interpreter services and saying you're mandated to do it, therefore you have to staff it, therefore it's in your best interest to do so efficiently. And I don't think that's likely to change unless, there's a more qualitative evaluation.
I'm actually doing a telemedicine startup where some of the data would be actually collected in a kiosk while the consult session is happening, and then at some point in time it'll make it to the EMR. So what kind of a liability thing we should be looking at as a company? And also, if we are actually setting this up at a kiosk at an employer's location, then what kind of liability would they be?
So the question is about storing medical data on a short-term basis in a kiosk and then uploading it to an EHR. And is there liability for the storage and transmission of that data in the kiosk setting? And the answer is probably that if you're going to be transmitting that to a healthcare provider, you're going to become a business associate of that healthcare provider, uploading data into an EHR or simply providing it in some other way. And so whether or not you have an independent requirement to implement some sort of privacy and security protocol for the patient, which I would argue that you may, you would probably have that as a matter of contract with your healthcare provider institutions that you're dealing with. I think, as I said before, like in the Federal Trade Commission context, you're holding data, even if you wipe it at the end of every day, you're holding patient data for some period of time, and you're subject to the breach notification rule under the Federal Trade Act. So I think you're caught both ways.
So should you go and buy some insurance, like how the providers would buy insurance?
Right. I mean, insurance is part of it, but you also need to implement a system of privacy and security protocols that will hopefully eliminate the need to call in your insurer for protection. Which your insurer will want to see if you ask them to write your policy too. They're not going to insure cowboys. They're going to insure people who have systems in place to mitigate risk.
Aaron?
Yes, sir.
You used two sets of terms, and I'm just wondering whether there's a conflict or not. At one point you said that the interpreter is ethically bound not to add or subtract anything from the conversation. In another place in your talk, you talked about providing culturally appropriate care. Can the interpreter intervene to educate the provider to the cultural conditions of the patient?
Absolutely. And you've touched on the heart, I think, of what the medical interpreter experience is defined by, because the whole point being, for instance, that you may use a term, right, that the patient may not understand. But the patient may use a term you're not used to. So let's say, for instance, that let's begin, I guess, with the provider side, because that tends to be, I think, easier for most people to begin with. So let's say, for instance, that we have a Cape Verdean Creole-speaking patient, from the Cape Verde Islands off of West Africa, and you just simply want to get some background information on the patient regarding, their health condition. If you ask someone if they have an allergy, that's not a 5-second question. It's a 10-minute conversation, because Cape Verde dialect, Portuguese, does not have a commonly understood term for allergy. So you're using a term the patient has no idea what you're talking about. It might as well be, a purple-headed octopus. So the whole point being, the provider asks the question, and the interpreter has to step out of that role for 1 second and say, doctor, nurse practitioner, I just want you to understand this patient does not actually understand the term allergy. So I'm actually going to have to engage them in an extended discussion in terms of, have you ever had one of these 1,500 physiological responses to any of one of these 1,500 potential triggers? And after 10 minutes, I hope to have an answer for you. Now, if you go to the other side, a patient may use a term that the provider's not familiar with. So for instance, let's say that you have a Khmer, Cambodian-speaking patient, who came to the United States in the 1980s following the Khmer Rouge disaster. It's entirely possible that if this patient has some issues related to loss of family members from the context of spiritual beliefs, they may talk about consulting a fortune teller. And you may not have a context to appreciate what that may mean. But it's a very understood practice within the Khmer culture that if you wish to communicate with dead relatives, you would consult a fortune teller, would make the appropriate offerings to the spirits, and attempt to offer some clarification about what recent health problems you may have, and how it may be related outside the physical world to the spiritual world. So that's the one specific, well, I should say there are two specific exemptions. So one is actually specifically related to, this communication question, right? To what degree can the provider understand the patient, and vice versa, because it is a two-way street. And then the second is the same as any other medical professional, that if we are, aware of or have reasonable cause to believe that either party is engaged in either self-harm or harm of someone else, that they're obligated to go beyond the bounds of their role and make the appropriate parties aware of that situation. So I hope that helps answer your question.
Now, can a nurse act as an interpreter?
That is a very tricky question. So describe your nurse. What's her background? Where was she born?
If she was a Chinese immigrant who was a nurse, she could speak Chinese and English, and if there was a Chinese patient.
Okay, so let's I think take a step back for a moment. So there are two separate questions here, because now we have a nurse, for instance, who's comfortable engaging this Chinese-speaking patient. Now we first have, I guess, the question of technical proficiency. So let's say, for instance, for the purposes of our discussion, that this nurse went through her nursing program at Bunker Hill Community College, or Boston College School of Nursing, or any one of the other very well-regarded nursing programs in the greater Boston area. Well, then the question becomes, how good is her technical terminology of medical terms in her mother language? Because I can stipulate the degree to which she understands it in English, because she could not possibly have passed her program otherwise. But then you have the reverse problem of someone who completed their medical training in Brazil and came to the United States and now has to make sure that they're equally qualified to do so in English. Now, there's actually a technical distinction between a bilingual provider and an interpreter. So, for instance, if that nurse is acting within her own scope of practice, engaging the patient one-on-one, then she is not an interpreter. She is providing nursing care under the scope of her existing license in a language other than English. But then as soon as the doctor says, nurse, please come over here, I have to ask the patient a question, then they're acting as an interpreter. And then there are actually very strict Joint Commission regulations that come into effect that say that at a minimum, the person must be tested, deemed competent in those languages, and authorized to do so by the hospital in that capacity as a portion of their duties. And that is a standard that is very rarely, if ever, met, which is part of the reason why people end up leaving themselves exposed unintentionally. One of the most frequent issues for this type of problem is actually the residency programs, because you have many residents coming from medical schools outside the United States, and the attending physician will say, you just asked the patient one of your questions, and now you will ask him one of mine. And then what ethical situation do you end up in? Where you need the goodwill of this attending physician if you intend to move beyond residency to fellowship and hopefully a practice of your own. And it places people in very difficult ethical positions.
Yeah, in that case, are you responsible if you end up being in a situation where you're an interpreter for some reason in a situation like that? Are we responsible if we just interpret wrongly or
Yes.
commit some? We are responsible for
And
that?
it ends up being very risky, especially because if it's outside the bounds of your job description, then you shouldn't be doing it.
But if someone in the hospital asks us because they have no other choice,
But see, that's the thing, that it comes down to a question of is there no other choice? Because then the fact of the matter is, it becomes a question for the Joint Commission, as well as for CMS and the Department of Public Health, that why is there not an interpreter services policy in place? Why are there not backup resources available? This is part of the reason why Stewart went with a technology-based backup system. The point being, there is always an appropriate qualified alternative, even if it's for a language that's very rare, that we did not know about in advance, that we don't staff for. There are still alternative venues that we can access and depend upon, and that's part of the reason why there's this emphasis, at least within Stewart during my time there, that we have to have tiers of support, that we have levels we can fall back to when we're in crisis. I hope that answers your question.
Actually, a question. Maybe as a provider, as representing providers, actually, I was thinking that if having a patient authorize the use of PHI kind of protects providers somewhat, sort of authorizing third parties to use it. You're talking about this patient data cloud, but in general, if that protects the providers and businesses from disclosure risks under HIPAA, why aren't there forms, or why isn't there just an additional form when a patient goes to a provider to get service that says, I authorize you to provide my data to a third party for use for X, Y, and Z purpose, which is, say, you could say no or yes, but there's an option at least to authorize use of the data in a more general way. Sort of some, why, I guess, wouldn't a provider want to give that option so they would reduce their risks for disclosure? Wouldn't a patient maybe be interested in allowing the data to be used?
Well,
I guess I'm thinking.
the question is about sort of giving a blanket authorization in advance to sharing of patient data as the patient may direct in the future. And I think there's a hesitancy to use sort of blanket authorizations like that because the rules actually speak to specific authorization. I authorize you to release X to